Thank you very much, Enrico, to accept our invitation. I'm not going to do a formal presentation. The students have already received a small text about your profile, and also Lorenzo. Thank you both. And I let you to begin, and please also present yourselves to our students. And thank you again for accepting our invitation.
Thank you again to you, Ruth and Hernani. I'm a biomedical engineer by curriculum. I'm actually associate professor at Politecnico di Milano. FESC stands for Fellow of the European Society of Cardiology. I work a lot with the European Society of Cardiology, also in terms of advocacy, medical affairs. So I'm involved also in these parts of not only science, but also, let's say, more practical actions which have an impact on the medical field. I'm also involved in mobile health. I'm a professor of e-health at Politecnico, and also at image processing. And if you find my CVs online, you will see that I am also involved in space research at different levels, let's say. But today, we are going to talk about a kind of a new topic that, as I said, I started a few years ago, and use of health geomatics. So I will start with a short introduction, and then Lorenzo will introduce himself and finish with a more practical approaches on what we have developed in these years. So, as it was known from the ancient times, location can influence our health. And you know very well, I think now with COVID, depending on where you are supposed to adhere to different rules, and you have a different perception of what the pandemic is. In general, different locations of Earth are associated with different profiles, which can be based on the physical description of the location, biological, environmental, economic, social, cultural, and even spiritual. So based on where we are, you are exposed to different variables. In 1854, a major cholera outbreak in London had already taken nearly 600 lives when Dr. John Snow, using a hand-drawn map, which is this one that you can see here reproduced, showed that the source of the disease was a contaminated water well, and he did this by representing on the map all the cholera cases on the district of Soho in London. And doing that, he could observe that the majority of the cases were concentrated around a particular dwell where the water was taken. And here you can see also the others on the map, but the majority of the dead was concentrated around this one. And so by simply closing the handle of this pump, the outbreak was solved after a while. And this proved this theory that cholera was transmitted through contaminated drinking water. So this is actually the first case reported in literature about the use of spatial analysis, spatial information applied to a health problem, actually epidemic. So if we consider both health and healthcare, intending health as individual and community health issues, and healthcare concerning also the service planning and management of healthcare resources. These are two intertwined concepts, and so their interaction is also important. We can talk about fundamentally geography of disease when we focus on the exploration, description, and modeling of the spatiotemporal incidence of a disease, or detection and analysis of clusters and patterns, or try to find causality analysis. And then we can talk about the geography of a care system, when the focus is more related to the delivery of health service, ensuring adequate patient access and also equity in access, determining the needs of the target community and service catchment zones, so the areas that can be reached by that particular service. And we don't have to add that this is a time-varying environment, because both disease, population, target populations, and resources are, of course, varying over time. I think that we are really expert in this kind of concepts now. Besides, we never realized just by looking at the notions that we hear at the TV every day. So from Earth geography, the discipline which tries to summarize and exploit all this is geomatics, or also known as geoinformatics, which is the science of technology and technology of gathering, storing, processing, interpreting, modeling, distributing, and using this georeferenced information. This is by nature a multidisciplinary discipline, which involves, of course, different, you see here, different fields, but also involves a lot of other subfields, which are reported below. And in particular, when we talk about geographical information system, this allows discover and visualize new data patterns and relationships that would have otherwise remained invisible. Usually, using a geographical information system, the data that comes from the real world is represented using different layers of information, which are matched in space, and through which is possible to make different queries and analysis, which involve all the layers altogether. And these layers can refer to different kind of variables and information that comes from the real world. These are general, let's say, variables used for geomatics. Then when we add the health component, it means that to these variables, we also add specific variables which are referring to the health context. And so we talk about health geomatics, which is, as I said, the use of this geographic information relevant to health through a geographic information system. In this way, for example, data on disease, the resources, the information from the environment, from the lifestyle of a target population can be inferred, can be measured and put together, both using the space and also considering the time information, in order to try to represent, for example, a disease model, and have a from one side a description of a phenomena, but also trying to exploit from this different decision scenario. For example, simulating how to allocate resources or forecasting epidemics, for example. Some basic concepts of spatial information. This is information where location has some importance. This location in general is not necessarily geographic. You can have spatial information refer to the human body. and refer to a disease assessing the spatial information based on, for example, where in the human body the disease is originating, or where is the part of the human body which is affected. So when we talk about spatial, it needs to be put into a context. If we talk about specific geographically referenced data, we refer to data which is referenced by a location on Earth, and this can be explicitly through latitude and longitude, or implicitly through an address, as when you do a Google search. And geocoding is the process for passing from an implicit to an explicit reference description. Also, we can have a 2D, 3D, or 4D kind of spatial information. And again, focusing on the reference system, besides that the latitude longitude is a world coordinate system, the geospatial information can also come based on different smaller systems, for example, for regional purposes. So there are a plethora of different coordinate systems. So what we have to do is look in your data and try to harmonize, for example, if you have different sources of data, in order to have them represented in the same reference. If not, of course, this is a problem. Usually, the geographic information stores two main types of data. One is the spatial data, which describes the location and shape of the different geographical features, which can be represented with points, lines, polygons, and in different layers according to the different features. And then attribute data, which is related to each of these features and describes its characteristics, properties, qualities, for example, number of beds, population characteristics, and so on. So this is the main idea of this spatial data. And using the geographic information system, you can merge different data into a single database and do the usual manipulation that you do in a database. Also selecting records, fields, sorting, listing, using Boolean operators, and so on. In addition, there is a possibility to use a bidirectional link, which means you can query the database resulting on a certain features on the map, or you can do the opposite. You can search on the map and finding the records in the database. So there is this bidirectional way of managing the data in this geographic information system. Talking about the data that we are going to work with in our presentation, we are talking about emergency services. So you know that there are three primary emergency services to which we can access, which is police, fire and rescue, and emergency medical services. In Europe, the usual number for the emergency service is now unique, is 112. I don't know, probably also in Portugal you have this. In Italy, we still have the 118 number active, which is a specific number for the emergency medical service. If you call it 112 and you say you have a medical emergency, then you are kind of redirected to the 118 number automatically. So, talking about our region, Lombardy, which you can see where it is in Italy, is the most populated area. Now it's about 11 million people. So I don't know how many people Portugal make, but
less than that.
I know that Lombardy is pretty big in terms of a region in Europe. We are probably 2 Belgian countries in terms of our population, or Belgium and the Netherlands together, or something like that. So you can see here that the emergency services are managed by dividing the region in 4 big areas, and each operating room manages the calls and the dispatch of a proper vehicle according to the call, which can be the ambulance with only paramedics, can be the ambulance with the physician on board, can be the car with the physician, can be the helicopter. So according to the emergency, different kind of vehicles can be started. And we have this collaboration with AREU, which is the Agency for Regional Emergency Services, that manages all this region, and with whom we are collaborating, accessing also to their data, which refers to ambulance dispatches and 118 calls. And we have done several researches in this field in terms of resource optimization, where to put the external defibrillators, about some relationship between disease and environment, and more lately, we were focusing on monitoring the evolution of COVID-19 and also predicting the evolution of a pandemic, of course, relevant to Lombardy region. So I give the ball now to Lorenzo, that will present you these practical examples, which are actually the fundamental topics of his thesis. So, Lorenzo, I stop sharing.
Yes, thank you, Enrico. Do you hear me properly?
Yes, Lorenzo.
Okay, thank you. Thank you. Good afternoon, everybody. Thank you for this opportunity to share my work with some colleagues. I also hope to, I'm here to learn something actually. So please do not have problems, do not pose problems in interacting. I will keep the chat open. So if you have any kind of questions, you can write in the chat, and at the proper time, I will try to answer all your chat. And I will also be very happy to collect feedbacks and suggestions from you all, because from what I understand, some of you have a more medical background and some other have a more technical and informatics background. And I am somehow in between, so I try to manage the whole process, but of course I cannot be expert in the whole process. So I'm trying to somehow make it real, but you have probably a background that is more powerful, more complete than mine. So I will be really happy to collect your feedbacks on both sides. So on the medical and also on the technical side. So really do not have problems in interacting. So I will try to give you an overview of my job during the last more than 3 years now. As Enrico said, I am in my last, hopefully, year of PhD. So I'm trying somehow to finish up, collect the whole work, and start writing my thesis. So that this will be my next challenge in the next months upcoming. So as Enrico started to say, I cannot show the chart. I wanted to keep the chat open, but
we can help on that, Lorenzo.
Okay.
If someone writes on chat, we tell you.
Oh, I managed it. Okay. So you see my screen?
Yes, perfect.
Okay, perfect. As Enrico said, we are collaborating with AREU, and I started working on this project for my master thesis during my during my path in university, I am also a biomedical engineer. So my degree is in biomedical engineering, but right now my PhD is interdepartmental between the Department of Biomedical Engineering and the Department of Environmental and Civil Engineering, because the whole part of the management of georeferenced information was actually in the environmental and civil department. So I'm trying to collect a little bit from both sides in this interdisciplinary approach. So my first project was related to out-of-hospital cardiac arrest. So I do not have to explain this to you. You all know that is a very serious medical condition. Actually, a person is considered to be dead when it is under a condition of cardiac arrest. So there is no heart beating at all. The electric and the mechanic activity of the heart is ceased at all. So the person is considered dead, and that's why we talk about resuscitation in this case. Being such a life-threatening health condition, a whole theory was developed in order to reduce the risk, because if an event like this happen outside of an hospital or in general a healthcare environment, the probability to survive are less than 10%. So it was necessary to work on it, and the whole theory of the chain of survival was developed, which is based on the early alarm, so calling the emergency medical services, early cardiopulmonary resuscitation. So many people, even non-medical personnel, was trained during the years to perform the cardiopulmonary resuscitation, and also an early defibrillation. So the earlier the defibrillation is performed on the person, the higher the probability of survival are increased. From scientific literature, we know that every minute that occur between the arrest and the first defibrillation, the probability of survival decreased by more than 10%. So an early defibrillation is really vital in order to give some chance of survival to the victims, and the limit time is considered to be 6 minutes. After the defibrillation, of course, it's still necessary to have some advanced life support from the emergency medical service, and also to assist in the post-arrest, so the medical follow-up of the whole event. So we focus specifically on the step of the defibrillation. As you might know, there are now worldwide several programs of public access defibrillation, which are based on the placement on the territory of automated external defibrillators that are publicly available. So people can retrieve it and apply it on the victim of an arrest in order to reduce the time of the first defibrillation. Of course, it is also necessary to train the lay rescuers, so the people that will eventually use the defibrillator, even though they are completely automated. So there are studies which demonstrate that they can be used by an untrained person in like 30 seconds more than a trained person. Why? Because as you can see in the image, you have all the instruction, and then these devices automatically record the electrocardiogram and decide if it is necessary to shock the victim or not. So the whole function is completely automated. The role of the lay rescuer is just to apply the electrodes on the victim. And also it is necessary to somehow raise the awareness of the population about this condition. For example, before I started working on this topic, I knew nothing about public defibrillation. So I was really surprised learning how important and how impactful this topic can be on public health. So as Enrico anticipated, we are working with Areu, which is the provider for Lombardy regions of emergency medical services, which provided us with the list of the intervention they performed on victims of out-of-hospital cardiac arrest. So in every intervention with an ambulance, they compile a survey with some fields that are collected in order to have a whole database of their interventions. And a specific attention is devoted to cases of out-of-hospital cardiac arrest. So in these cases, they also record if the person was defibrillated with a public defibrillator or not, and also they collect all the other information, so the theology of the event, the georeferentiation. So in automatic, they record the coordinates, the geographic coordinates of the intervention, which is a very important part for us in order to process this information from a geospatial point of view. Also, obviously, they record some information about the victim, like the age, but those databases are anonymized, so we do not have any sensitive information about the victims. So the aims of the study was somehow to evaluate how the public access defibrillation program was performing with a specific reference on the city of Milan. So for this specific study, we focused on Milan, which is the capital of Lombardy region and has a population of almost 1.5 million people. So it's not comparable to other cities around the world, but in Italy, it's quite important as a city. So in order we wanted to evaluate somehow the policy about public access defibrillation, but also to identify if it was possible somehow to improve the strategy and to improve the whole process of public defibrillation and to develop a decision-making support system. So those was the objective on which we started this project. So a little bit of technical note before going into the solution. And this is probably more interesting for the informatics. I will talk specifically with reference to QGIS. QGIS is a specific geographic information system. So it's a software which is specifically developed for the handling of georeferenced information. Why QGIS? Because basically it is open source. It is completely open source, so you can access to the whole code of the program. You can modify the whole code of the program. Obviously, it is free, so you do not have to pay to use it, but also it is iteratively developed by the user. So every user can contribute in the development of the software by, at first, programming and releasing plugins. So they are like add-ons, so additional functionalities, which, if they are working properly and they are interesting for the users, are progressively included into the new releases of the software. So the software itself develops with the user and the contribution of the user, not only as feedback about how they use it, but also from the very programming point of view. Of course, they have internal programmers which handle the main aspects, but they really use the programming parts of their user. I also had the chance to participate into an international conference, which was oriented to the overall environment of the open source geospatial information. And I really was surprised by how they feel like a community. It is really a community of people passionate with this topic, which all contribute in a very open optic in order to provide really some help to the whole society and to progress all together into this new discipline. So it was really interesting to see how deep they believe into the open source idea and the open source approach to the programming. So about the programming language, QGIS is programmed in Python, which means that you can modify and do all sorts of operations onto the source code by programming in Python. Also, using Python functionalities, it is possible to produce a standalone application, which is what I tried to do with the Qt module. I don't know how many of you knows about Python and in general object programming languages, and if they know what a module is, but if you don't, it's not that interesting. Anyway, there are specific functionalities already built in to develop a graphic user interface. So it is possible to develop within the Python environment a graphic user interfaces which uses all the functionalities of QGIS, including, of course, the mapping, which is basically the main function of geographic information system. So from a technical point of view, that was my approach. And this is an example of what is obtained. So this is the basic user interface, which I developed in Python. You can see here a mapping of a zoomed portion of the city of Milan. And you can see a menu with some custom functionalities that I brought. So it is project-based. You can develop a new project, and when you create a new project, which is like a new page, let's call it, it is possible to load some predefined data sources. So, of course, beside of this user interface, there is a part of extract, transform, and load of the data sources. So I start from the data sources which I'm provided with. So in these cases, some of these data are provided by AREU, so specifically the out-of-hospital cardiac arrest events and the georeference database of defibrillators. But many of these data, like the roads, the buildings, the administrative data, are open data. So basically, I use OpenStreetMap in order to extract information about the topology of the territory. So from the custom and location-specific structure of the data, there is a first phase of transformation into a standardized structure of data sources, which then I apply for the whole evolution. I decided to do this effort of a preventive part of extract, transform, and load because it is necessary if I want to replicate and to scale this same application onto new territories. Also, I am presenting this work about the city of Milan, but I did the same research for Canton Ticino in Switzerland. So I already tried to export the whole model and to apply into a new territory, and it is possible. It was successful. So these are the data sources. As you can see, I start from the database of out-of-hospital cardiac arrest, the location of the defibrillators, roads, buildings. Milan is the territory of the whole city, and then there is Milan subdivision, which is an internal subdivision of the city into administrative areas, which are called local identity nuclei. So LINs as a subdivision. So the first part of the platform is the analysis of what I call the supply. So to analyze how the defibrillators can contribute in handling the medical emergencies. How it is done? It is done by computing the catchment areas. So basically the catchment area are those areas that you can see in the picture are the area around the defibrillator where the defibrillator can be retrieved and used within the limited amount of time available for an effective intervention, which is in scientific literature 6 minutes. So we did some investigation about the dimensioning of these catchment areas, because in literature there is not a univoc definition of how to convert the time indication, 6 minutes, into a spatial indication. This is unknown. We have to study it a little bit. At the end, we settled for a dimension of 200 meters. Of course, this is thought to be applied in cases of intervention by feet. So people that is running, so they assist to an arrest, they run toward the defibrillator and they retrieve and apply it to the victim. So this is the whole algorithm that I'm using to compute these catchment areas. I will not go too much into details unless you are very interested in it, but maybe we can come back at the end of the presentation and focus a little bit more about the algorithm. The one thing that I want to underline is that, as you can see from the picture, I am not using circular areas. In the traditional, in scientific literature, so in the traditional approach that is applied to this topic, catchment areas are computed as circular areas. But you can understand that the problem in a very urban environment like the city of Milan is that, okay, the circular area is not actually representative of the distance that a person can travel. That's why I decided to focus on the computation of what I call topological catchment areas, because they are based on the actual topology of the streets, of the roads, and the paths that people can go in order to intervene with a public defibrillator. Is it actually worth it to do this effort to develop realistic catchment areas compared to circular catchment areas? Yes, it is. I performed a whole study, in this case, not only on the city of Milan, but on all the defibrillators that are placed in the region of Lombardy. And you can see that the actual difference that you obtain as a dimensioning of the catchment areas, the difference is consistent. So the two methods of computing the catchment areas are statistically very different. Also, the dimensioning, because in traditional scientific literature, the circular areas are computed with a radius of 100 meters. But if we compute realistic catchment areas with a target dimension of 100 meters, they are too small, basically. It's what you are seeing in the picture. So that's why we decided to enlarge it and compute 200 meters catchment areas. So 200 meters catchment areas are much more similar on an overall to 100 meters circular areas. But still, the difference is very significant. So we think that it's really necessary to compute realistic catchment areas. And this is a first glimpse on the power of geographic information handling, how can really help into make analysis more realistic and more fitting to the real world scenario. So once that we compute these catchment areas, it is possible to compute the coverage that the defibrillators provide in terms of OHCA. So looking retrospectively on the database of the arrest, we want to know how many happened within these catchment areas. So that's the main information. Okay, now we know what area are covered by the defibrillators. So how many events actually happened within this area? So if an event happened within the area, theoretically, it was possible to intervene with a defibrillator and to reduce the time of first defibrillation. But also it is possible to compute the coverage in terms of resident population. And also we wanted to focus on the overlapping of these areas, because basically this is a suboptimal use of the resources, because if two devices are covering the same area, the probability that the two devices are needed at the same time in the same place are zero. So it is a suboptimal placement of the devices. That's an example of the report that you can obtain with this application by computing the coverage. So in this example, you can see that looking retrospectively of the events, in the city of Milan, 42% happen within the catchment areas of the defibrillators, while 58 are not. So why the vast majority of events does not happen within the catchment areas? We found out that the main problem is that public policies are focused on the placement of the defibrillators in public areas, like squares or, I don't know, train stations, subway stations. But we discovered that more than 80% of the out-of-hospital cardiac arrest occur in homes. So basically when people is home, not when people is walking around the street or is waiting for the train or other things like that. So that's why the whole placement of the defibrillator should be investigated and maybe modified a little bit. So that's an example of the kind of report that you can expect by the analysis of what I call the supply, so the availability of the current resources. The next step is to analyze the demand. So trying to understand where the defibrillators are needed. And this is done by the computation of a risk map. So you can see here a mapping of the whole city of Milan divided into cells, and the color in each cell, I will go more in details quite soon, but as you can imagine, the color represents the level of risk. So red is a higher risk, while green is a lower risk. This is how it is computed. Okay, I know that there is a lot of text. I will not go too much into details, but the idea is actually to subdivide the territory into cells, and for each cells compute a purely geographical function. So just on the base of the geographical characteristic of each cell, a risk is tried to be predicted. So I started thinking about a machine learning algorithm, but in the end, I found out that actually the variations of this function are not so significant that it is possible to actually apply some, let's call it deep learning algorithm. So I decided to do something a little bit at a lower level, a little bit more simple, which is basically a polynomial interpolation. So I am computing an estimator by interpolating the function of each of the attributes that I consider. So I started from 35 attributes that was reduced, then applying principal component analysis to 8 attributes. Specifically considering and applying the principal component analysis separately on attributes which were related to demography, so like the age and the sex distribution of the population, the ethnicity, so where actually people were from, so subdivided into ethnical categories of people, and also considering some land use and social economical indicators. So those are the attributes. It is a combination of what is presented in scientific literature to be meaningful and what it was actually possible to retrieve. Actually, one of the reasons why I decided to focus on the city of Milan is because the municipality of Milan is much aware of the importance of data, and they have a lot of open source database that they provide to the population for this kind of projects. So that's why it was actually possible for Milan to have some very specific insight. Like I had the computation of the distribution of the age of population year by year. So it was actually possible to do some very deep statistical analysis of the age of population. So this is somehow the preparation of data. Anyway, what I obtain is a final estimator, which is the representation of my purely geographical function. Why do I call it purely geographical? Because, okay, in this case, you can see here the result. They are not so specific, and they depend also on the administrative areas mainly. Why? Because most of the attributes, it was not possible to compute them on the specific cell, but it was necessary to compute them on the overall administrative area. So that's why you can see this less, let's call it less pixelated representation of the risk function. But this is just the first step. The second step is to actually compute the resident population in each cell. To do so, you can imagine it is necessary to have an estimation of the people living in each building of the city. It was possible. Of course, it will never be a precise measurement, because to have a precise measurement of this kind of measure, we need a census, basically. Otherwise, it is impossible. But it is possible to estimate it on the base of the volume of the residential areas. So that's the explanation of my algorithm. Once again, I will not go too much into details, but if you're interested, we can come back on it. Anyway, let's say separately on every administrative area on the city, I try to compute how many people in average live in each, let's call it a cube meter of residential building available. And then computing the whole volume of the building. And this information is available for as open source by OpenStreetMap. So it was possible to give a first estimation. Once that I know the people that are supposed to live in each building, it is possible to compute it in every cell. And that's the distribution that I obtained. As you can see, it is much more similar to the final map, which is this one. So here I apply the geographical estimator, so the geographical risk, as a weight to the number of population. And then the final risk is scaled 0 to 1. And here you can see a representation of the final risk. So yes, it is mainly based on the people living in each cell, because that's the main factor. So we understood that more than 80% of the arrests happened at homes. That's why the people living in each cell is the main factor contributing to the probability of having an arrest in that cell. But also we try to increase and improve, enhance somehow this estimation by including some geographical aspects. And that's our final result. Of course, it was validated. I will not present the rock curve representing the validation, but we obtain a very significant performance about how this function estimates the probability of occurrence of an arrest. So once that I have a good analysis of the supply, so the available resources and the demand, the final step is to somehow compute an optimization. So the functionality that I built, once again in Python, was to somehow compute a new deployment scenario. So imagining and simulating a new distribution of the defibrillators and see what performance can be achieved. So that's the interface. You can see that there are many parameters that can be settled. So basically, it is possible to set a constraint. So let's say I want to install 100 new devices, or also I have a budget constraint. So I have, I don't know, 500,000 euros to install new defibrillators. Or I can set a performance. So, okay, on the retrospective database of arrest, I want to cover 90%. Or talking about the risk function. So I have a risk function. I want to cover 80% of the risk. How many devices do I need? And what is the budget? And this is done not only by installing new devices, but if you want, and if you opt the option, it is possible also to include redisplacement. So some devices which are placed where they are not needed in this model are simulated to be redisplaced somewhere else. And that's how you can obtain a different performance. That's the output. So you can see in blue, the devices that are maintained in their position. In orange, the devices that are redisplaced. And in green, the new location of devices. Okay, you probably know nothing about the geography of Milan, but here in this map, you can see in the upper left corner, many orange areas. So this is corresponding to the very center of the city, which is a very touristic area. So there is a lot of people going by, and that's why public authorities installed a lot of defibrillators. But you can see in the mapping that if you analyze the performance, these defibrillators are not useful, and they are supposed to be redisplaced. You can see the green areas, which are in more residential areas. Of course, this is just a zooming of the city, but the idea is to move out of the touristic and public areas and to focus on the residential one. That's the main lesson that we learn about this topic. And of course, you can print out a report which gives you an idea of the different performance. So in this example that I am reporting, this is based on the installation of 100 new devices. So the overall budget is 433,000 euros. So the redisplacement that I suggest are 366. So almost 37% of the currently installed devices should be redisplaced. Of course, you can imagine that the redisplacement of a device is much less expensive compared to the installation of a new device. And that's why first you have to redisplace whatever you need to, and then you start installing new devices. So that's why the number of redisplacement is even higher than the number of new devices installed. And this is the performance that you can reach. So you can see that the coverage, of course, this is the coverage of retrospective events. We cannot know about the future coverage, but the coverage of retrospective events can pass from a little more than 40% to almost 70%. So the increase is 27% of events covered. So that's just an idea of how the algorithm can work. So that's it about out-of-hospital cardiac arrest and public access defibrillation. I was ready to somehow extend this analysis to other medical emergency, because you can also think about stroke or myocardial infarction. Of course, in this case, there is not a public defibrillator that you can redisplace. But I was starting to think about the actual distribution of the ambulances, because you can imagine that Areu have some contracts with other association of volunteers, which which manage the ambulances and the medical emergency interventions. So they have somehow, they have a need to understand where the ambulances can be needed and also when. So you can see that here the time component, there is something, because in the analysis of the performance of the defibrillators, I also consider the time availability. Because you can imagine that if a defibrillator is, I don't know, in a school, of course, it will be accessible only when the school is open, and it is a big limit. So there is a little bit of time component, but it's not that important. When it comes to intervention with ambulances, the time component is vital. And also the distribution is about the stationary location. So after an intervention, where should the ambulance return? There are now some projects also, I know in the UK, specifically in London, about dynamic placement. So the ambulance does not have a fixed point of return after the intervention, but it depends really on where the intervention happened, where is the hospital where the patient was lived, and also by the day of the week and the time during the day, because it affects a lot the probability of having a different information. So I was ready to work on all of that, but then 2020 happened. Okay, here, sorry, I forgot. I have also the references of what we published talking about out of hospital cardiac arrest and defibrillators. So the first one does present the development and the validation of the application that I just showed you. The other one is a Congress proceeding, which is related to the comparison between realistic and circular catchment areas. So it is more a statistical analysis to prove that the two mapping techniques are actually different. So if you are interested, you can go a little bit more in depth with these publications. But I was saying, I was ready to work on all that. And then 2020 happened and we had the pandemic of COVID-19. So as you can imagine, I was working with geographic data. And we all know in last years how important the mapping, the distribution of what is actually an health event become important for all of us. It was really an explosion of the idea of map representation. I don't know about you, but I think now almost the whole population sees at least one map every day. Maybe now not once every day, but it was maybe in the first phase, but let's say once a week. So we all get a little much more used to this kind of representations. So I decided to start working on it. As you can imagine, we had not a clear idea on how to approach the analysis, on what to do, because we were all very surprised by this situation. So I just started to analyze a little bit the data relevant to the SWOPs. So the actual official diagnosis of cases. And you can see in this very simple mapping how powerful the representation it is if you consider different measures. So on the left, you can see the representation of the total number of cases, while on the right side, you can see the representation of the ratio between the number of cases normalized on the resident population. And you can see how different the two mappings are. And I don't know about you, but I was really surprised. And now it's been more than a year, and I'm still surprised on how low the literacy about this kind of representation is into the news and basically on the print. So if you want to see a representation which at least give you a normalized measurement, you have to go and look for it. You will never see it on the television. You have to go on the internet and actively look for it. On the television, yes, maybe sometimes in some programs which go more in deep, you can see something, but the representation that we all see is the one of the left, which in my opinion is very misleading. If you want to have a clear idea of what's happening, the one on the right is much more powerful. So this was a first example on why I decided also for personal interest, because in this first phase, the whole information was a little bit confused. So I was also personally interested in analyzing this data and trying to understand a little bit more about the situation, about what was happening. This is another example of how powerful the representation is. So in this case, we see on the left the active cases, so the current cases, while on the right side you can see the total cases, and overlapped onto the regions you see these pie charts, which on the left represent the distribution of people which were home and of people in hospitals. And you can see among the regions that it was very different. While on the right, you can see the difference between active cases, people that were already healed, so did not have any more symptoms and were considered negativized, and casualties. So in white, you can see the number of casualties, which is very different among the different regions. This is another example of an indicator that I wanted to analyze. So it is the ratio of total cases with 6 days of difference, which was considered to be the average time of incubation according to the first report of World Health Organization. So in the first report from World Health Organization, which analyzed data from China, they said that the average time of incubation was 6 days. So I decided to look at the ratio in cases with a 6 days distance. You can see here charting, and this was after the lockdown. So by looking at this chart, you can see how after the lockdown, the situation was getting better. But once again, after the lockdown. So I also tried to compute this value separately for every 10,000 residents. And in this way, I obtain what is basically a distribution of data, which I plotted in these box and whiskers charts. And you can see here in the first three how all the indicators, so the median and all the percentiles was raising, while after the lockdown, it started to decrease. So from March 17th, which is actually 6 days after the lockdown of the whole country in Italy, these values started to decrease. So the acceleration is negative, and it is a slowing of the epidemic. And here you can see during April, so now I'm still talking about 2020, during the whole month of April, those values were continually decreasing. So we could actually see how the lockdown was being effective in controlling the pandemic. But then we started to think about how significant the data that we are analyzing was, because you can see, you can imagine that data related to the swabs, so the official diagnosis, may be consistently affected by the policies. First of all, by the availability of the resources, but also by the policies. So in these charts, you can see the very different situation between two regions in Italy. So the first one on the left is Lombardy region. It is what we are talking about. The one on the left is Veneto, which is another region adjacent to Lombardy. So it was not on the other side of the country, it was adjacent. But you can see in this chart how different the situation was, specifically in terms of people tested. So you can see that the percentage of people resulting positive to swabs was much lower in Veneto. Why? Because they were doing the same number of swabs, but the population is much lower. So they were testing much more the population, and that's why you can see this difference in the data. And it's also probably the source of the very different case fatality rate. In the first phase, so on April 21st, 2020, in Lombardy, we had a case fatality rate of 18.4%. Now we know from scientific literature that the expected lethality of COVID-19 is between 0.5 and 1. So this gives you an idea of the underestimation of the cases that was performed by the swabs, by the official diagnosis. And why? Because we didn't have the resources. So only people in hospital with very severe symptoms was tested. And that's why we see this very high case fatality rate. And if you move to the region adjacent, you see 6.8, which is, I don't know, 1/3. So you see how impactful the policies and the availability of resources was. So we understood, okay, we cannot look at this data. They are not significant. They are very biased by the whole context. So we started to think about our collaboration with Areo. So it is possible to actually estimate the evolution of the pandemic by using the intervention of ambulances, like we were doing for the out-of-hospital cardiac arrest. As I said, in this database, we have the etiology of the intervention. So we know if it is a cardiac arrest or, like in this example, respiratory or infective etiology. So we started to filter out the database of intervention considering only respiratory issues. And this is the first analysis. So you can see in the chart on the right, in the chart on the left, sorry, the plotting of all the different provinces of Lombardy region. So on the right, you have the mapping. So you can see the region and the subdivision into provinces, which is a lower level administrative subdivision of the territory. So for each province separately, we computed the number of casualties related to COVID-19. So not the official diagnosis, but the casualties, because we suppose that they were less biased because, okay, people are tested only if they are in hospital and they have severe symptoms, but if they are very severe and they then die, probably they are tested. Unfortunately, we know now that this was not the case. So we must know that there were many casualties related to COVID-19, which were not recorded because our whole healthcare system was out of its capability of handling the situation. So unfortunately, it is sad to say, but many people died at home without a diagnosis, at least during this first phase, which struck very hard, especially in the area that you see pictured in dark red on the right. So that's the area where the incidence was higher. And really, even now in this area, you see a much lower incidence compared to all the around areas right now in 2021. And this is probably because in the first phases, the ratio of people affected was so high that, okay, we cannot say that we have a community immunity, but we are going towards that by natural means, so without the vaccination, because so many people was affected that even now you can see the impact. Anyway, you can see on the left basically that we try to compute a correlation between the number of casualties and the intervention of ambulances, specifically for respiratory and infective etiology. And you can see that the correlation is quite high. So we said, okay, we can use this kind of data to at least estimate somehow the diffusion of the pandemic. Of course, you will also have some intervention with respiratory or infective etiology, which are not due to COVID-19. There will always be, and we will not be able to know it. But the raising in this number was so high that the part not caused by COVID-19 was so small that it can be considered noise on the signal, so it can be neglected. And that's why we decided to use this kind of measurement to do all of our analysis. So what was the analysis? First, I will have once again to talk a little bit more about the subdivision of the territory. So here you can see a different subdivision, which is not based on administrative areas, but is based on the resident population. So we have the official recording of resident population for municipalities, which is even smaller, of course, of provinces. Municipalities are, I don't know how you call it, but are single cities, basically. So for each city, we know the total amount of resident people. So I started to aggregate municipalities until I reached a target dimension of 100,000 residents. So you can see that this subdivision that you see in the map, each district is around 100,000 residents. Of course, there are deformities, but the median value for is very close to 100,000 residents. Of course, the single cities, which if you consider a single city like Milan, which is 1 million and more people, okay, this is a district. So there are some districts related to single cities that are where the population is too high, so you cannot, you do not have to aggregate. You already reached the target dimension with one single city. But the other districts are quite uniform. So this is a population-based subdivision. Why did I decide to do this kind of subdivision? In order to have a more robust statistical analysis. So a statistical analysis computed on a uniform amount of people is probably more significant. And why was it necessary to aggregate municipalities? Because many municipalities were too small. We had, I do not remember exactly, but like 500 municipalities with less than 2,000 residents. So you can imagine that the number of ambulances intervention is not significant, because you have like one during one day and then 10 days without anyone. And if you have a 2 on 2,000 residents, it is a very high value, but it is not significant. So that's why we decided to do this kind of subdivision of the territory. So that's the kind of the analysis that we applied separately on each district. We compute on each district this, let's call it COVID-19 score, which is based on the number of ambulances normalized on the resident population in each district, but also weighted according to the sex and the age of the victims. Why? Because we saw that during here we are still talking about the first peak of the pandemic. So we are in March and April 2020. We saw that the sex and the age distribution of the victims which required an intervention with ambulance for respiratory or infective etiology was changing consistently during this period. And how? First of all, we had much more males compared to before, so less women, much more males. And also the age was consistently changing, let's say, the number of people above 75 years old, yes, it increased, but not so much. While the amount of people below 75 and above 65 years old increased really a lot. So the ratio on the overall amount of interventions, the share of this age mesh was very different. So we decided to use this information as a weight to compute this score in order to weight more the phenomenology typical of COVID-19 as observed. Okay, I have to specify that this is a retrospective analysis. So we started working on this analysis in April 2020, and the data that you are seeing here are stopped on the 23rd of March. So it is retrospective. We did not have the chance to go live. You can imagine how busy Areo was with the emergency. So we started to analyze when the emergency was starting to I don't call it under control, but at least manageable somehow. So this is a retrospective analysis and gave us this opportunity to weight differently the different characteristics of the victims according to the observed phenomenology of COVID-19 victims. So that's what we did. We compute this kind of value for each district. And what you see here is basically a signal. So we decided to analyze by using signal processing techniques. Specifically, we decided to somehow identify the expected starting point of this raising curve that you can observe. And to this scope, we used a technique that was actually developed in the analysis of ECG, specifically for the detection of the ending of T wave. So you can see here the contamination of the biomedical aspect and the geographical and georeferent part of the information. So we use this technique based on the computation of a trapezium. So the B and C points are fixed. The A point is the point where the derivative of the curve is maximal, and the D point is iteratively moved across the signal. The point where the area of the trapezium is maximized, okay, that's the D point represented the expected start of the curve. This is an algorithm that is, as I said, validated in the analysis of the ACG, and we decided to apply because actually the problem was very similar. So we had a signal with an expected morphology and some noise superimposed. So that's the typical condition of the analysis of the NACG, and we therefore applied this technique. Okay, you can see here that actually considering different districts, the morphology of the signal was very different. Specifically, we identified 4 different morphologies. The first one is very sharp and very evident. The second one, the B, is still very evident, but not so sharp, so a little bit smoother. In the third one, we had much more noise. So there is still some signal, but the signal to noise ratio was much smaller. While in the D morphology, actually, we have no signal. We are just observing some noise. So according to the different morphology, of course, the processing of the signal was a little bit different. Specifically thinking about the filtering part of this signal. It was different for the different morphology. But at the end, what we obtained is an estimation in all the districts of the starting point of the curve. So once again, here you have the reference because this part of the study is already published. So you can, if you're interested, you can see how we, more in detail, how we developed and validated all these algorithm, let's say, framework. And you can see how different the results are in the territory. So we have some areas where the flex point is identified on the 14th of February, and notice that the first official diagnosis was on the 24th of February. So here we see the starting of the curve 10 days before the first official diagnosis. So this is another proof, but now it's well assessed that the pandemic began much earlier than the official diagnosis. But you see some other areas where the flex point is identified on the 9th of March. So you can see a very consistent difference in the starting point across the territory. Also, I wanted you to, I underline the district 65 and 53, which are the 2 that you see in the middle. And this corresponds to the area that was hit harder by the first peak of the pandemic. So it is the area with the highest number of casualties and one of the area in all Europe with the highest number of casualties. Really, the emergency there was something very hard to deal with. And as I was saying, we still see the effect because right now, I don't know, probably you know nothing about the situation in Italy right now, but we are in a situation of raising. So we are locked down. We are now in lockdown. Actually, the new lockdown started yesterday. So in the very beginning of a new lockdown phase. But in this area, 65 and 53, you see a much smaller number compared with, we will see later, compared to the rest of the region. Probably because so much people was affected during the first peak that they develop a very consistent immunity. And we detected
also, if I can add, also a lot of people died, which was the most, let's say, fragile one. So that was, if you have like exterminated a certain class of people, of course, these people cannot die twice. So this is also why this area are now, let's say, less hit. But is the area of Nembro, where probably also you have seen the videos of the military trucks that take out all the coffins during the night in a kind of procession. So it was really, really impressive.
Yes, exactly. the number of coffins was so high that we could not dismiss them. We had to ask help to the military force in order to handle with the number of coffins. And there are, if you look on the internet, you will see pictures of it, and that's the area we're talking about. So this confirms actually the reliability of the model that we implemented. But of course, we also have some false positives because not all the areas that are in red did have this dramatic explosion of cases in the next weeks. So yes, we have some relevant results, but they are not perfect. And that's why we are still assessing and refining a little bit our parameters in order to improve this framework. Anyway, once we obtained this kind of results, we also started to think about the territorial difference that we saw, which were very consistent. So we asked ourselves, okay, what is causing these very consistent differences? One hypothesis is that it was due to the pollution. So we know statistically that Lombardy region is one of the most polluted areas in all Europe. And this is due to the geographical and orological conformation of the area, because we have mountains on 3 sides and then a whole plain and a little bit of sea at the end, which is very small. So you can check on the internet, but the configuration of the territory make the circulation of air, of winds, very low. And that's why the pollution is so static, and that's why the area is so polluted. Also, we have a very important industrial and also agricultural activity, so they generate a lot of pollution, but also the characteristic of the territory does not allow to dismiss this pollution. And that's why it is one of the most polluted areas in Europe, unfortunately. And a lot of scientific literature was published about the possible correlation between the diffusion of COVID-19 and pollution, both regarding velocity and lethality. So the results of the scientific studies that you can find does point out a specific correlation between particulate matter, so both regarding particulate matter 2.5 and particulate matter 10. So they identified this high correlation between the diffusion, both in terms of velocity and lethality of COVID-19, and the concentration of these pollutants, at the point that it was hypothesized that the particulate matter, maybe you read something about it, was supposed to act as a physical carrier for the airborne diffusion of the virus, because some particles of the virus was found out on particles of particulate matter. So it was supposed that it could help the diffusion, the airborne diffusion below the 1 meter or 2 meters that are considered to be the safety distance to avoid the contagion by droplets. So this was an hypothesis. But when we started to think about this phenomenon, we started thinking that this could be a case of Simpson paradox. What is a Simpson paradox? You see here a representation. So on the left, you see a data distribution. My apologies, I know these charts are not so, from a graphic point of view, are not so convincing, but I'm not so skilled in charts, so just forgive me and try to look at the meaning that I want to pass out. So on the left, you see an overall distribution. And if you compute a linear correlation in this data distribution, you see that 41.29% of the variance by computing the correlation coefficient is explained by the variable y. So the 41.29% of the variance in the variable x is explained by the distribution of variable y. If you see on the right, we suppose that this distribution, that on the left, we look as an overall. On the right, we suppose that the 3 parts of data that you see depicted with different colors are generated in different geographical areas. So if you analyze single geographical areas, you can see that you cannot detect anymore this linear correlation. So data are uncorrelated in this case. This is an example of the Simpson paradox. the Simpson paradox says that the correlation might be even negative. So if you look at the overall distribution, the correlation is positive. If you see at geographically separated correlations, you will see a negative correlation. That's the idea of the Simpson paradox. So we suppose that this could be the cases. Why? Because particulate matter is generated by human activity. The area that are more consistently inhabited by people, where the human activities are more consistent, are characterized by a higher concentration of particulate matter. And if we go and look at the diffusion of COVID-19, specifically if we look at the official diagnosis, you can expect that you will have more diagnosis in more urbanized areas, because the density of people is higher, there are more hospitals, and probably it's also easier for healthcare system to reach these people compared to people that live in the country or in the mountains. So we thought that maybe it was biased. So the two phenomena, both the larger number of positive cases to COVID-19 and the higher concentration of particulate matter, could be generated by the same phenomenon, which is anthropization. So basically how anthropized is an area. So we decided to have a look at, to separately have a look at geographical areas with similar characteristics from this point of view. And that's what we did. So we exploited, in this case, an open source database, which is provided by Lombardy region, which collects all the information relevant to the use of the land across all the territory. Is the first map that you see on the left. So we divided the natural area from the agricultural area, the industrial area, and the urbanized area. Then we also considered a socioeconomic indicator, which is the average amount of tax paid by resident population. And we used these measurements to perform a clustering of the municipalities in Lombardy region. And on the right, you see the result of this clustering. So we obtained 5 different classes. Actually, the number of classes is a parameter that we set manually. So we tried to perform the clustering algorithm with different number of classes, and we evaluated the best result as 5 classes. So these are the final classes that we applied. So these areas are comparable from the point of view of the land use, and also from this socioeconomic indicator, which is a well-being indicator. So for an indicator of wealth of resident people. So the clustering was performed on municipalities, but of course we wanted to perform analysis with our custom district of 100,000 people. So that's the subdivision of districts among classes. Here, once again, we had to set a threshold in order to assign a district to a specific class. So if 70% of the municipalities belonging to a district were of the same class, then we were able to assign this cluster to this district to a specific class. And you can see here that some districts were not assigned because the composition of the municipalities was too deform. So that's why we were not able to use all the districts for this analysis, but that's the final result. And you can see here on the right in the table that the composition from the land use point of view is very different of these classes. So we have class 0, which is mainly agricultural, while class 1 is basically all natural. Class 2 is the most balanced between the different components, and it is much urbanized, but also we have some natural areas, some agricultural areas. So we consider it to be the most urbanized. Class 3 is once again mainly natural, but you can see that the mean tax contribution is much higher. So while class 1 was, yes, natural and very low inhabited, class 3 is natural, but people is more wealthy. So that's the difference. While class 4 is once again a little bit balanced. So you can see agricultural area for 33%. So 1/3 agricultural area, 1/3 the natural area, and the other part is separated between urbanized and industrial area. So this is, we call it mediumly urbanized. So these are the classes that we obtained with the clustering. And for each district, we decided to compute the average concentration of some different pollutants. You can see here particulate matter 2.5 and 10, nitrogen oxide, nitrogen dioxide, ozone, carbon oxide, ammonia, and sulfur dioxide, and I do not recall the English term for the last one. I'm sorry, benzene. Okay. And these are the pollutants that are recorded across the territory of Lombardy. So the map that you can see on the left is a representation of the recording station for these pollutants. So for every district, we computed the average concentration of these pollutants considering 3 different exposure times, which is 1 month, 6 months, and 12 months. Of course, we did not use a single record because you can see that depending on the districts, the number of stations is different. So we computed for every district a weighted average of the 7 closest stations, considering the distance between each station and the centroid of the district as the weight to compute the weighted average. So in this way, basically, we obtained some time series, some values for the exposure to these different pollutants for every district. The next step was to consider a measurement for the velocity of diffusion of COVID-19. Once again, we already discussed a lot how the swabs test and the official diagnosis were not significant from a statistical point of view. So that's why we decided to stick with the ambulances. We had this data in this collaboration with Areu, so we exploited the number of ambulances, and specifically we developed this method. So you can see on the right a plotting of the number of interventions day by day. These data are filtered with a 5 days moving window of average, so they are not raw data, but a little bit filtered in order to reduce the noise. So we plot this distribution day by day, and then we compute the exponential regression of this distribution, which is the blue line that you see. Here, the exponential regression is in the form that you can see in the formula, and we consider the lambda parameter, which somehow give the evaluation of the slope of this exponential regression as the parameter estimating the velocity of diffusion. So the more sharp is this exponential, the more quick we consider it to be the velocity of diffusion of COVID-19. So that's the measurement that we decided to use.
Lorenzo,
yes?
Information, you have to close in maximum 10 minutes.
Okay, yes, I will do it. I'm almost at the end. I know that I'm going a little bit long, but it's going to be not so long anymore. Okay, I can skip this because this is basically just an exemplification and a resume of everything that I told you. But the idea is to obtain a chart like the one that you see in the middle. So you can see that each point represents one district belonging to the same clustering class. And the 2 values are on the X variable. So in the independent variable is the concentration of a pollutant, considering all the different pollutants and all the different exposure time, while on the y-axis, you can see the lambda parameter, so the estimation of the velocity of diffusion of COVID-19. And basically, once that we have this kind of chart, once again, we compute a regression function. So in this case, I'm representing the exponential regression, but we also computed the linear regression. So once that we have the regression function, we compute the correlation coefficient. And the correlation coefficient can give us an idea if there is a correlation between these 2 measurements. So pollution and velocity of diffusion. And these are our results. So we identified let's call it consistent. Okay, it's not so high. You can see that the correlation coefficient values are slightly above 0.6 with ammonia. So we found out that the pollutant, which is mostly correlated with the velocity of diffusion, is ammonia, which is something really unexpected because you cannot find it in scientific literature. I did not find any reference difference of correlation with ammonia. And also ammonia is usually, I mean, sometimes it's not even considered as a pollutant because it is basically correlated with the production of secondary particulate matter. But ammonia in itself is usually not even analyzed. And what is even more interesting is that the highest correlation is found in class 0 and class 4. And if we go back and see at class 0 and class 4, you can see that these two classes are the one with the largest share of agricultural area. And we do know that ammonia is actually produced by agricultural area. So that's the main result that we obtained from this study, even if we are still working on it and trying to understand a little bit more about this possible correlation. And what about particulate matter? So my apologies, these charts are still in Italian. I do not have the English version yet, but you can see on the left the different the representation of correlation coefficient for the 3 different time ranges for ammonia in the different classes. And on the right, you can see the same for particulate matter 2.5. So basically, we did not identify a correlation with particulate matter. So maybe actually it was a case of Simpson paradox. So the correlation identified in literature is indirect, it's not a direct correlation. However, we also did some analysis in relation to the lethality of COVID-19. And in this case, we also found a little bit of correlation with PM 2.5, which is the chart that you see below. So if we consider mortality, then yes, there is a correlation with particulate matter 2.5. And this really makes sense because we know that particulate matter 2.5 can cause inflammatory states, which were proved to generate more severe cases of COVID-19. Okay, the last part, then I'm done, is coming back to the first point. So once that we identified the flex point, we asked ourselves if this data structure was can be used to generate real-time alerts, so running alerts day by day. So we started working on a labeling of the data. So you can see here the charts. Once again, I'm sorry, I know that the legend is superimposed. Do not pay attention to it. So starting from the flex point, we labeled as zeros all the data on the left and as 1 all the data on the right. Then from this signal, we extracted some features which, okay, on the top part of the data structure, you can see the signal. So these are the signal in a 7 days window. So we selected 7 days of signal, considering both the intervention of ambulances for respiratory of the infection causes, as always, and also of calls to the emergency number. So not only the actual intervention, but also the calls of citizens to the emergency number. And then we extracted some parameters like the median value, the standard deviation, and also the parameters of the linear and of the exponential regression. So starting from this signal, we generated a whole set of attributes meant to be applied for machine learning, basically, because we wanted to develop an algorithm which was capable of detecting the difference between the left side of the signal and the right side of the signal day by day, so giving a new record each day. And that's our basic training set for the algorithm. Of course, it was necessary to do some fine-tuning of the parameters. So first of all, to assess which features were more significant in the definition, in the final performance of the machine learning algorithm, and also trying different algorithms. So we tested support vector machines, random forest, and a Gaussian. And basically, we are obtaining the best results with a random forest. So the machine learning algorithm, once that is all setted, once again, I'm going fast on it. If you're interested, we can go more in details about the setting. But basically, we obtain an automatic labeling, which is 1 if the probability is above 0.5, and 0 if the probability is below 0.5. So we decided not to use directly the labeling of the algorithm, but to somehow use the probability. So you can see here that considering windows of 7 days, they result in a value of probability. Then we consider a window of 5 probabilities, even if right now we are working on the definition of this window, we are probably changing it. So if we consider the last day, we are considering 5 windows of 7 days. We have these 5 values. So we consider the mean and the mean variation. So this gives us an idea of the confidence. So we are sure that the probability is low or uncertain or high. So low is below 0.4, high is above 0.6. Between 0.4 and 0.6, we consider it uncertain, but also the variation on this window. So, okay, it is low, but it's increasing. It is uncertain, but it is decreasing. And we obtain this combination of the different values into 5 classes. We tested the significance of these 5 classes by considering, of course, retrospectively on the training set, the number of ambulances in the next 7 days according to their assigned class. And we saw that the difference in this data distribution is significant using our rank sum test, which is a non-parametric test because the distribution is non-normal of this data. So we use this statistical test to assess the difference, and the difference is significant. So that's the result. You can see here on the left the mapping on the 5th of March of 2020. So during the first peak, and on the right on the 5th of November of 2020. So during the second peak that we had in Italy, and you can see how the situation was different from a territorial point of view. And here it is the current situation. So you can see that basically we are in the very middle of a new raising phase. But however, you can see from how the algorithm is trained that we are not giving an estimation of how severe is the situation of epidemic diffusion. We are just giving an estimation of the confidence of being in a phase of diffusion. Because if we look at our data set, we want to distinguish between the left side and the right side. So our algorithm is just trying to estimate if we are on the left side or on the right side. Once that we assess, okay, we are on the right side, so we have a consistent diffusion, we are in a phase of active epidemic, but we do not know if we are at the beginning, at the peak, or even in a decreasing phase. We are now working on a little bit different training set in order to distinguish between the raising and the decreasing phase. But at the moment, what we can say is that unfortunately we are in this condition. So in almost the whole territory of the region, the pandemic is active and it is spreading. So I have finally some KPIs, which I will not go into details, but somehow they give an overall and global idea on the situation on the whole region. But once again, from the point of view of the territorial diffusion, not on the intensity of the pandemic phase. And this is the historic records. So you can see perfectly the 2 peaks. While the smaller peak on the right, in the blue chart especially, is related to a little bit of raising that we had after Christmas. So during the Christmas period, of course, we had more interaction between people, and this caused a little bit of raising. While this is the current situation. So yes, the situation is raising, but you can see that compared to the other phases, in this case, it is more linear. So we are still in a phase of expansion of the pandemic, but it is linear. It's not exponential, at least from a territorial point of view, as it was in the past. So yes, the situation is not good, but not comparable at all to what we saw in the past. So I'm done. This is my little bit of summary, the take-home message that I want to give you is the overall idea of the method that I apply. So I collect and pre-process georeference data and apply machine learning or other predictive model using the very powerful environment of geographic information system, which even allows to develop graphic user interfaces. Why? In order to develop a model of geographic risk of any adverse pathological event, but also of analyzing the demand of different resources. In order to, my final aim, my final goal is to develop decision-making supports, which can provide knowledge insight for policymaker in order to plan the distribution of the resources and the intervention needed. To resume even more, my idea is to apply a method which does not simply transform data into information, but goes a little bit further, transforming information into actual knowledge. That's the main effort that I'm trying to do with this method that I'm trying to apply. So I hope that it was a little bit interesting. Sorry if I went a little bit long. But as you can see, I'm very passionate about this work that I'm doing, and I hope that my thesis will be as convincing, from this point of view and significant. So that was all from me. Thank you all. If you have questions, I will be more than happy to discuss with you.